I would love to invite Dr. Shuvro sir on the dais for IR approaches in treatment of hepatocellular carcinoma. Sir is well known, and I really don't know whether I'll be doing any justice in introducing him. Sir, the dais is all yours.
Thank you very much. And it's a pleasure, and many thanks for the organizers for the invite. So I'm going to talk in 12 minutes to give you an overview of liver-directed therapies in HCC. Now, you all know that in 2022, the European Association of Study of the Liver came up with this revised BCLC guideline, very complex one. I'm not going to go through this entire slide, but suffice it to say that HCC management is multidisciplinary, and it starts from transplant to resection to ablation of various forms, so radiofrequency, microwave, cryoablation, to the various forms of transarterial therapies, which includes, of course, chemoembolization and radioembolization, and great advance in the systemic treatment, resulting in improved lifespan. And the other very important concept in BCLC in 2022 is the concept of stage migration. So it is a dynamic staging. The patient's condition, the liver condition changes over the course of treatment, and one has to be prepared to either shift to the left or to shift to the right, depending upon the situation. So I'll just illustrate this thing with one particular case, an interesting gentleman, 71-year-old, who presents with dyspepsia and bloating to another hospital in the south. Ultrasound reveals a small lesion in segment 6, no jaundice, no portal hypertension, controlled diabetes for 10 years. So basically a BCLC A, child A, alpha fetoprotein was under 7. His performance status is 0. He is otherwise okay, presumed to be NASH. There is some element of chronic liver disease. And CT shows a 2.2 centimeter segment 7 lesion like this. The previous imaging, I had to struggle to get them all, but I don't have movies, but this is the lesion. So after, I'm sure after multidisciplinary discussion, this can be ablated, but this was quite rightly, otherwise a fit guy undergoes a segmental resection, has a right posterior segmentectomy, which is uneventful. This is what it looks like. This is 2017. In 2018, he presents to the same team with a further nodule in segment 4A like this, and this time, post-resection, he is treated with microwave ablation. He's well for 2 years, from 2018 to 2020, and then he presents in February 2020, again to the same team. And this time we have got some movies, and there are a couple of interesting things here. So there appears to be some nodules around segment 7, few nodules in segment 8/5, and a very subtle nodule in segment 3, which would be very difficult for you guys to pick up there. So the segment 8 nodules don't show any washout. So they are kind of LIDADS 3/LIDADS 4. So what this patient gets is so these are the MRs again, and as you can see that those lesions don't show washout. The segment 3 lesion is difficult to see, only faint arterialization on arterial phase CT. So he undergoes a right lobe TACE. I don't know whether it was a drug-eluting bait TACE. I guess it was, because I didn't see any lipidol later on, and a left lobe microwave ablation. So this is in 2020. So he presents to us in August 2020, and his clinical condition is the same. He still drives to work, lives on his own, very independent. Diabetic, hypertensive now, previously not. Performance status still 0. Alpha fetoprotein now is 8.24. So it's kind of a non-secretor. We can't rely on alpha fetoprotein much. So this is the MRI that we done. And as you can see on the MRI, that there is this particular nodule that does not show washout. Then this does not show washout. So it's a LIDADS 4. And here is a very subtle arterialization at the site of the previous ablation. So this was the lesion that was treated with ablation, now has got marginal recurrence, which is one of the issues with ablation, and we'll talk about that in a second. So this is the venous phase, and in the venous phase, you can again see that that lesion does not show washout. And the segment 3 lesion, the arterialization around the previous ablation shows some washout. So this is presumed to be a recurrent HCC at the site of the previous ablation. So we do an microwave ablation. The stomach appears to be very close in this particular picture. Normally, we would do an hydrodissection. Hydrodissection means putting air or water in between your target lesion and an organ that you've got to save, for example, the stomach. So we did put some water, but typically in the stomach, in the gastrohepatic omentum, the water doesn't stay. It kind of floats back. So it is good to use air as a pneumodissection. But actually, if you look at multiplanar, the stomach was not that close, so we were happy. We proceeded with the ablation, and we got this ablation volume. You can see this ablation volume and this concept of A0 ablation, very similar to what you guys would do in a resection. When we talk about an R0 resection, we would like to think about an A0 ablation. And in terms of an A0 ablation, it is really important to have multiplanar views. So the tumor must be covered not just on the axial view, it must be covered both on sagittal and coronal views. So you must have a 3-dimensional sphere that overdoes the 3-dimensional tumor by at least 5 to 10 millimeter margin. So that is the way you can prevent a recurrence. So when it comes to ablation versus surgery in our multidisciplinary meeting, if the patient is suitable for both, how do we choose? Of course, patient choice comes into being, but generally speaking, if it's a subcapsular lesion, there is a tendency to go towards surgery. If it's a deeper lesion, then there's a tendency to go towards interventional treatment. If there is more cirrhotic liver, goes to interventional treatment. So therefore, we chop and change based on the location, based on the patient's other factors. But suffice it to say that almost all lesions can be treated by ablation, almost all lesions can be treated by surgery. So it is not that this has to go to surgery and this has to go to ablation. But what really matters is A0, and really matters. If you have got a tumor which is marked by the T in that particular thing, you need to get an overwhelming margin around it, exactly like you would do in surgery. So, and it must be in all 3 planes. And RF used to be the gold standard. We have done it for 15 years, but I must say that microwave has overtaken RF in terms of the speed, in terms of the size, in terms of the A0-ness that you can get with microwave. And we have got this technology called the thermosphere or the high sphere technology, by which you can get a bigger round sphere. Previously it used to be like the map of India, now it is more like the map of Australia. So you get a much more rounder sphere. So June 2021, the patient's on follow-up. This movie didn't work for some reason, but he has no washout, it looks very good. So now in July 2022, remember this is good 5 years after he presented. So now we can see that there is probably some more nodules. They don't classically see washout. Now, are you able to see the the ablated region? Looks very nice. The ablated region looks very nice, but there are few nodules now on the right lobe of liver. So we bring him down for a TACE, and I'll talk about. So this is not an easy TACE. You can see the faint blush in the right lobe. There are 2 or 3 areas of faint blush corresponding to the MRI. So TACE you can do lobar, you can do selective, you can do ultra selective. If you go by the Japanese and the Koreans, Shio Miyama and the group from Osaka, etc., you would see that actually super selective TACE. TACE is normally considered to be a palliative procedure because we are dealing with the BCLC-B. But when you have got a small lesion, particularly when you have got multiple lesions, rather than doing 3 or 4 ablations, doing super selective TACE is a very good option. And the Japanese have shown that super selective TACE can be curative. And by super selective, I mean right into the subsegmental vessel. So here on this picture, you have got the tumor blush. It is from this particular branch. So you see my microcatheter is here and this particular branch, and you can see the faint blush. Now, normally you would see much better blush than this, but this was not a very hypervascular lesion. So now this is post-TACE. You can see the lipiodol uptake. Now when we talk about levels of embolization, this is what I wanted to say. You can have lobar, you can have segmental, or you can have super selective like this. And when you have super selective embolization, you have got much better. So this is inferior phrenic to cover the upper part of the tumor. You can see the lipiodol uptake on the fluoroscopic image. And this is a cone beam CT showing that excellent uptake of the tumor, of these 2 tumors. So this is super selective, and super selective gives a much better control and a much better cure rate. And you should aim to achieve a super selective. So anyway, we go ahead and do super selective for that segment 8 lesion. Then we go to the other lesion. We are not able to identify even which vessel very nicely. So we do go sort of selective rather than super selective. You can see that there is a blush here, not a great blush, but we go and put lipiodol, and this is the post lipiodol. Now There was also another lesion in caudate lobe. I forgot to show you that on MRI. This is the caudate lobe. Caudate lobe arteries are very difficult to identify, and they can be very difficult to even on CT, on MR, particularly if you do MR instead of CT. And one of the disadvantages of MR is that the spatial resolution being slightly lower, very small arteries are not so well seen. So, so this is the post-TACE angio. You can see the blushes have gone except the one in the caudate lobe. So what I thought was this was already about 2 hours. So we will bring this patient back and schedule for a microwave for the caudate lobe lesion. So, of course you need kit. And I have not talked today about radioembolization. I have not talked today about the difference between conventional transarterial chemoembolization and drug-eluting bead chemoembolization. Difference in opinion. The Precision 5 study showed that DC bead is better than conventional chemoembolization, particularly in the setting of larger tumors or with reduced liver function. But the Japanese and the Koreans would strongly contend that, and they would say that conventional, old-fashioned conventional chemoembolization with appropriate catheters is a very good technique. But you must do this with the help of cone beam CT, and embolization to do in the presence of cone beam CT, which means that you've got a CT scanner in your lab, and what that does is it proves that you have actually treated the whole tumor. So embolization is much better done with cone beam CT. Of course, we have a dedicated interventional CT, we have a cone beam CT cath lab, you need all the kit. So these procedures don't come cheap. So in conclusion, I just wanted to say, I'm well within time, that the guy is well, still driving to work. I got a message from the daughter, I wanted a picture, but she said I can only send it this morning. But what I wanted to say was HCC management is multidisciplinary. It must be done in a multidisciplinary setting. BCLC staging is dynamic. There are broad guidelines as to what we should do, but it can be individualized, and we should be able to change depending upon the progress, depending upon the progression, depending upon the response. There are lots of interventional therapies available. Within microwave, there are lots of options. Within transarterial therapies, there are lots of options. But it is something that we need to work together. Thank you very much for your attention.
Thank you, Dr. Roychaudhury.